Okay, so good evening and welcome everybody. Thank you for joining the Canadian Celiac Association's webinar, Could It Be Celiac Disease? Presented in part, I promise, gluten-free. They are our tonight's sponsors. I am Gauri Bava, a registered dietitian on the client support desk of the Canadian Celiac Association, and I'm joined here today with Melissa Seacott, the Executive Director of the Canadian Celiac Association, and our presenter for the evening, Dr. Mohsin Rashid. For many of you joining us today, you may suspect that gluten is a cause of symptom or ill health you or your family members may be experiencing. Our plan is to walk you through to learn more about this disease, how to get diagnosed, and what steps to follow next. The Canadian Celiac Association is a small national charity, and for nearly 50 years, it has been led by volunteers and experts as a source of evidence-based information and peer support. We advance advocacy on key issues such as safe food and labeling, deliver education programs and services, and invest in research to empower those living with celiac disease and gluten disorders. May is Celiac Disease Awareness Month. And along with our trusted friends at Promise Gluten-free, we have been reaching out to Canadians to help alert them to signs and symptoms of the disease. We are also down to our final days of How Do You Sandwich, a social media contest. You still have a chance to win a year of great sandwiches, a $1,000 prize package, courtesy of Promise Gluten-free. Be sure to visit our website, www.celiac.ca, for more details. Promise gluten-free breads and bakery items can carry the CCA gluten-free certified trusted remark that they are gluten-free, wheat-free, dairy-free, vegetarian, soy-free, very high fiber, very low sugars, and low saturated fats. 2 slices of Promise Gluten-free give you 36% of your required daily fiber recommended by the Canadian Food Guide. Promise Multigrain Loaf is packed full of superfoods such as linseed, sunflower seeds, and quinoa. Perfect for making a quick sandwich. The texture is soft and it doesn't fall apart. So remember to sandwich. So before we start, I would like to review how the webinar works. All the participants are muted so that everyone can enjoy this session with minimal disruptions. If you have a question for our presenter, please type them in the question and answer box. We will get to them in the end of the presentation. I apologize in advance. If we cannot get to some of the questions, you can email us your questions at info@celiac.ca. We will be pleased to respond. However, please keep your questions brief and focused as it helps to provide more information. There is a chat box available to chat between yourselves. However, please do not ask questions via the chat box as we intend to use the questions in the question and answer box to answer all the questions for later. The session will be recorded, so if you would like to review the material on tonight's session, we will email you a copy of the recording along with the PowerPoint slides. I would now like to introduce you to our speaker for the evening. Our speaker for tonight is Dr. Mohsin Rashid. Dr. Rashid is a leading pediatric gastroenterologist and a professor of pediatrics at the Dalhousie University in Halifax, Nova Scotia. He also volunteers for the Canadian Celiac Association and is a past member of the Professional Advisory Committee. Before I hand over the stage to Dr. Rashid, we do have a poll. It's anonymous. A few questions that help us understand you better, that helps us put more perspectives in things. Please feel free to answer. And I'm going to launch it right now. Thank you in advance for answering. So I will now.
This is great, Gauri. We're getting a great participation tonight.
Yes, I can see that. And I would say thank you once again. All these answers help us go a long way.
We're just over the halfway point of everyone. Just
Oh,
click
yeah.
your screen to answer the each of the 3 polling questions, and we'll show the results in a second. Let's give it.
Just, I think, a couple of more seconds. We are over more than halfway through. So,
All right, let's share the results.
okay. So, you want me to end polling now?
End, yeah, and then you can share.
Okay, here we go. Share results. And we can see, have you or your family member been diagnosed? Yes, over 50 with celiac disease with blood work or biopsy. Over 52% have responded yes. For those who have responded no, listen carefully tonight. We have a lot of information coming out. If you or your family have not been diagnosed with celiac disease, have you already gone gluten-free? 37% say yes. 33% say somewhat, but they eat some amount of gluten. And 30% are still eating gluten. So let's see how that's going to help us and what we need to do about it. If you have been diagnosed with celiac disease, are you the first in your family that you know of? 56% is a whooping yes, and 44% no. So let's see. I'm going to hand over the stage to Dr. Rashid, and then we will take it from there. And Dr. Rashid, the stage is all yours. I'm going to stop sharing my slides. Please go ahead, share yours. Oh, crap. Sorry.
Okay, thank you very much. Can you see my slides now?
You need to share your screen.
Oh, sorry. Just hold on, please.
No
Yes.
problem. The joys of technology.
I know.
Here we go.
Yes.
How's that?
Perfect. You're on your way.
All right, great. Well, thank you, everybody, for joining in. Hope everybody is doing well and staying safe. So the title is, Could It Be Celiac? We are required as physicians to disclose any kind of competing interests. So there are no financial disclosures about this presentation. And only thing is that I do volunteer for the Canadian Celiac Association. I've been doing that for the last almost 20 years. So there's so much to talk about celiac disease. I mean, we can go on for hours and even days, right? But for the purpose of this talk, I'm going to focus on 3 aspects. We'll talk about what are the clinical features, what are the signs and symptoms of celiac disease? How does this disease present? We'll talk a little bit about diagnosis. If you think you have celiac disease, what's your next step? And we will go over some broad principles of management. Once somebody is diagnosed, what to do after that. And again, as mentioned, you will have an opportunity to ask questions at the end. Can people hear me? Okay.
Sound great.
All right, great, thank you. So, you know, the sky is pretty clouded. All these terms are being thrown around, both for the public and in the medical profession. And it's getting kind of confusing. What is celiac disease? What is gluten sensitivity? What is wheat sensitivity? Non-celiac gluten sensitivity, wheat allergy, gluten allergy. So it's really becoming quite problematic. So I thought before we go to celiac disease, which is the bulk of our discussion, we should try to clear some issues around terminology. So there are actually 3 groups of disorders which are caused by gluten, what we call gluten-related disorders. So first of all, we have IgE-mediated disorders. So these are like allergic in nature. For example, you know, just like you may have heard about peanut allergy, somebody, and those can be very serious at times, where people can get a rash, they can get breathing difficulty, swelling of the lips. So these are mediated by IgE, or what we call type 1 reactions. So here we have wheat allergy. So somebody could be allergic to wheat, and that can affect different parts of their body. It can give them respiratory symptoms like cough and wheezing, shortness of breath. It can give them bowel symptoms like pain and diarrhea, or it can give them skin symptoms like rash or eczema. So that's one group of problems which are allergic in nature. Second group of gluten-related problems are autoimmune based. So we all have an immune system in our body, and immune system is responsible to fight off any infections. So when we get a bacteria or virus invading our body, although antibiotics and medications may help, but eventually it is our immune system that gets rid of that infection. But immune system is also very smart, and it knows what is a foreign object or a foreign enemy and what is part of our own body. And in some situations, our immune system becomes a little confused and starts to attack our own body. And this happens in many, many different diseases. Celiac disease is one of them. Another one would be like people have heard about thyroid problems, right? Thyroid is a gland in the neck, and sometimes the immune system goes and attacks the thyroid gland and destroys the thyroid gland, and now the person has to take pills by mouth to replace the hormone, the thyroid hormone. This can also happen in type 1 diabetes, where the immune system goes and destroys those cells that make insulin in the body, and now the person has to take injections of insulin to make up for that. So celiac disease is also an autoimmune problem, and there are two other autoimmune diseases that are caused by gluten, and we'll talk about that a little bit later on. One is called Dermatitis Herpetiformis, or celiac of the skin, and the third one is called gluten ataxia, where the person may have a problem with their balance and their gait, and that is because of gluten. And the third group of problems, which is still being worked out, are related to non-celiac gluten sensitivity. So this is, we don't sure exactly what this is. This is a diagnosis that people base on their symptoms. So they don't have celiac, they don't have wheat allergy, but they get symptoms when they take gluten. There is no damage to the bowel, their blood test is all fine, but they get symptoms when they take gluten, and they feel better when they stop taking gluten. So this is called non-celiac gluten sensitivity. So what is this beast gluten? So gluten is a protein. It's an umbrella term. It's not one protein. And it is present in 3 grains: wheat, barley, and rye, and any other crossbred grains, for example, triticale, right? But these are the 3. Everything else is gluten-free. And the word gluten is derived from glue. So this is a protein that keeps the bread together and prevent it from falling apart, right? So this is one of the big problems in gluten-free foods, is that the bread or the confectionery is not bound properly because it doesn't have gluten in it. So there are different types of gluten in wheat, there are different types of glutens in barley and rye, but for practical purposes, we just use this umbrella term called gluten. So celiac disease, as I mentioned, is an autoimmune disorder, and it has all the components of autoimmunity. First of all, one has to have a genetic predisposition. And there are 2 genes that are necessary to get celiac disease. They are called HLA-DQ2 and DQ8. If you don't have these genes, you won't have celiac disease. You won't have celiac disease now, and you will not develop it in the future. With almost 99% assurance or sensitivity. There are always going to be exceptions, but for practical purposes, you got to have these 2 genes. Now, the problem with these genes is that they are not abnormal genes. They are not mutated genes. These are normal genes, and about 40% of the population is carrying these genes. So having the genes doesn't mean that the person has celiac disease, but the absence of these genes means that the person does not have celiac disease. So there are situations where this genetic testing may be helpful actually to rule out celiac disease. Number 2, we know what the antigen is, or what is that particular chemical against which our immune system is acting. and that is an enzyme called tissue transglutaminase, or in short, TTG. For those of you who have celiac disease, you probably had a blood test done, and this blood test is actually anti-TTG antibody. So our body, our immune system makes antibodies or chemicals against this enzyme in our body called TTG. But most importantly, what's unique about celiac disease compared to all other diseases is that we know what the trigger is, what the culprit is that starts the process of autoimmunity, and that is gluten. So when the person takes gluten, the immune system gets activated and attacks the gut. And if you remove gluten, all the damage to the gut will recover. This is very unique for celiac. There's no other autoimmune disease where you can reverse the process of damage to the body. So celiac disease occurs because of a complex interaction between our immune system, gluten, and our intestine, our small intestine, which absorbs our nutrients. So we need genes, but we also need environmental factors. And a lot of environmental factors have been blamed, but we don't know for sure if one or more factors is essential. For example, the most common environmental factor that people will describe is a bowel infection. So they say, I was feeling fine, I got this infection, a virus, a stomach flu, and then celiac disease came out. Other illnesses can also trigger this. For example, pregnancy is a common trigger. So the lady is feeling fine and then got pregnant and celiac came out. Trauma, surgery, operation, even emotional stress has been blamed as one of the triggers that starts celiac disease. So celiac disease can happen at any time in a person's life after 5-6 months, as long as you are taking gluten. So we see babies with celiac disease, 8-9 months, 1 year old, and we see children and adolescent, and I've met many people in their 80s and 90s who develop celiac disease. So celiac disease knows no age limit. This is very, very important to understand. It's not a children disease, although it's very common in children, but it can happen at any age once the person starts to take solid foods or gluten in their diet. So these are just some images. So if you look at the intestine, the small intestine with a scope or endoscope, this is what the bowel looks like. So you see this nice small sort of round circular folds. And we have these folds because we need a lot of area to absorb our food when we eat. Because we only have like 2 or 3 hours for the food to make its way from the mouth to the lower end, as we call from the gum to the bum, right? So the lining of the bowel is not flat. It's not like a tube. It has these folds. And if you look with the microscope, on these folds are these finger-like things, small finger-like things. They are called villi. And there are millions and millions of villi. They are hanging in the bowel. And this is under the microscope. You see these long finger-like projections. Now, the reason we have this villi is that we have a lot of surface area from where we can now absorb our nutrition. So if you open up the bowel, the small intestine is the size of a small table. But when you open up the bowel with the villi, the size of the small intestine is that of a tennis court. Huge, huge, huge. So celiac is a disease of these villi eventually. It causes damage to the villi. So here's a patient with celiac disease. So you see the difference between this and this. So the folds are very swollen. They look very inflamed. And it's actually a condition we call scalloping. You see these little cracks in the folds like a scallop edge. And if you look under the microscope, you don't see any villi, right? This is where the villi should be if you just compare to the left. And if you look under the microscope in more detail, it's all flat. It's almost like a lush lawn, and somebody came with a lawnmower and they've mowed the lawn, right? So there are no villi. And once the gluten is removed from the diet, you will be going from this back to this. So there are no diseases really in medicine which can be treated so effectively by removing one particular thing in the diet. So there is complete reversal of all the damage that happens. So celiac disease is a very common problem. It's one of the most common bowel diseases, and we estimate that it affects about 1% of the population worldwide. Some countries more than others. But we call it a hidden epidemic because 80% of cases are undiagnosed. Although the number of diagnoses is increasing, but the vast majority of people who have celiac disease, they don't know they have it. So this is some data looking at celiac disease by confirmation with biopsy and celiac disease by blood test. Because not everybody who has a positive blood test gets a biopsy. Right? They don't want a biopsy or they never get to a biopsy. So overall, the differences between, you can see some differences between continents, but more or less, it's about 1% of the population. So it's a very, very common problem. It's there in Africa, it's there in Asia, in South America, in Australia, and certainly North America is a hotbed for celiac disease as well. In the past, we thought this was a European disease, but now we know that we have actually a lot of celiac in North America. Oops, sorry. So what are the symptoms of celiac disease? So I've listed the typical symptoms. The typical symptoms of celiac are belly pain and diarrhea. Right? And this can lead to weight loss because one cannot absorb nutrients. So a person may actually present with weight loss. They may not have a lot of diarrhea or belly pains, but they're just not gaining weight or losing weight. And in children, it can impact their growth. So the child is not growing at the right rate. It can also lead to poor appetite because of all the discomfort and pain. People just don't want to eat. It sometimes can cause nausea and vomiting, especially in children. Constipation, right? This is sort of counterintuitive. You would think that you can't absorb nutrients, so you would be getting diarrhea. But sometimes people will present with constipation. In fact, constipation now is more common than diarrhea as a symptom of celiac disease. And then bloating and big belly or distended belly is also one of the features. So these are what we call the typical classical features. But what's important is that the vast majority of people now, they don't present with the typical symptoms. So these are some of the non-classical symptoms or other ways people will present. And in adults, the most common way celiac disease presents now is with anemia, which means low blood or low hemoglobin. That's what makes our blood red. And this is most often due to low iron or folic acid, which are nutrients we need, vitamins we need to actually make blood cells. So if you're not absorbing these nutrients, your blood will become low. So some people can present just with anemia without any other symptoms. So anybody who has anemia and we can't find a cause, we should actually look for celiac disease. This is what we recommend to our medical trainees. Another peculiar presentation is short stature in children. They have no other symptom, there's no pain, no diarrhea, but the child is just short in height. They're not growing appropriately. So celiac is one of the most common causes, most common diseases that can lead to short stature. Sometimes short stature is familial, right? The mom or dad may be short. But I always tell people, if mom or dad are short, maybe they have undiagnosed celiac disease, right? So we should screen them as well, look for celiac in parents as well. So short stature is very important. Mouth sores, what we call canker sores, recurrent oral ulcers. This could be the only symptom of celiac disease. Then a long list of dental problems, and one of them is enamel defect. So the top part of the teeth is not developing properly, or the teeth are not coming out in time. So that could be a manifestation of celiac disease, undiagnosed celiac disease. Bone disease is also common. I've listed osteoporosis, so bone pain, joint pain, or unusual fractures. And these are related mainly to nutrient problems because of lack of absorption of vitamin D and calcium. So the bones are not formed and the person develops osteoporosis. So anybody who has early onset osteoporosis, one should look at celiac as one of the causes. Another peculiar way celiac can present is with liver inflammation. So liver enzymes are elevated, they're abnormal without a particular cause. So one should look for celiac disease in that situation. I remember meeting a gentleman once. He's a young, probably in his 30s, And he had this issue. I think he had a little bit of a fatigue or something, and somebody did his liver enzymes, and they were high. And his doctor said, "Listen, you should stop drinking alcohol, right? Because one of the common reasons liver enzymes go up is because of alcohol." And he said, "Listen, I don't drink," but they wouldn't believe him. And he had his enzymes repeated again, and the same thing, his enzymes were high, and they kept blaming on alcohol. And in fact, the poor gentleman had 2 biopsies of his liver, and those were just showing inflammation without a cause. And then somebody saw the light and said, "Oh, maybe this could be celiac," right? And he had celiac disease. So, and it can lead to a fair bit of liver damage, actually. So if somebody has liver issues, celiac is one of the things we should look at. In females, menstrual problems are very common. Menstrual irregularities, irregular periods, and infertility, very important, another important one, both in males and females, but especially females. So if a lady cannot conceive without any issue, without any reason, rather than doing a lot of expensive $1 million workup, one should look for celiac disease. And once they get diagnosed and they go on a gluten-free diet, the fertility improves. So this is another very peculiar way celiac disease can present. And then there's a long list of neurological problems. Balance problems, as I mentioned, ataxia, inflammation of the nerves, neuropathy, giving pins and needles and numbness in limbs, and depression and anxiety, and there's a long list. So we can actually talk about just neurological problem for several hours. So these are some of the other unusual ways or atypical ways that celiac can present, and the list is not complete. For example, fatigue. Extreme fatigue is another very important and very common way celiac can present. But I just wanted to highlight some of the outside the bowel, what we call outside the bowel symptoms. So Dermatitis Herpetiformis, or in short DH, is the skin celiac disease. So here the person presents with very itchy blisters. So itchy rash is usually symmetrical, both sides, on knees, on elbows, can happen on the face and back as well, on the body. And it is very, very itchy, and it's very chronic. So these people may not have any bowel symptoms, and one can make a diagnosis with a biopsy of the skin. They don't have to have a biopsy of the bowel. You can make a diagnosis by a dermatologist, skin specialist, and the treatment is the same with the gluten-free diet. They sometimes require medications as well. So the key here is that this is very, very itchy. It's not like simple eczema or psoriasis. Very itchy, chronic rash that is not getting better with medications. So one should think of celiac. Once you have one autoimmune disorder, a person is at risk of getting more than one autoimmune disorders. And celiac is a good example of that. So anybody who has an autoimmune disorder is at high risk of getting celiac disease, and anybody who has celiac disease is at high risk of getting other autoimmune disorders. So I've listed 3 of them, which are the most important ones: thyroid, type 1 diabetes, and liver diseases, which are autoimmune in nature. Now, some of these are complex. You don't need to remember all the terms here, but just remember that if somebody has an autoimmune disease, thyroid, type 1 diabetes, liver, or rheumatoid, they should be screened for celiac disease, especially if they have any symptoms, because it's very common. These are some other associated diseases. IgA deficiency, which is a protein, and sometimes they can have other diseases, Turner syndrome, Williams syndrome. So there's a long list of diseases that are associated with celiac disease. It also runs in families. There is a high familial risk in celiac disease. Anywhere from 5 to 15% of the first degree relatives of a patient with celiac disease may have celiac disease. This is really, really important. So this is a picture of 2 twins. If the twins are identical, what we call monozygotic twins, 70% risk, but not 100%, which means that genes are not everything. There are some other environmental factors as well. You can have the same genes in twins, and one of them may not get celiac, right? If it is non-identical, the risk is still high at 30%. The highest risk in family members is to siblings, so to brothers and sisters of the patient. So here are two, and I want you to think about which one has celiac disease. So unfortunately, we can't get your answers, but I'm sure people can pick up. So this boy has celiac disease. Why? You can see he's shorter than his identical twin, and he's got a bit of a big belly, bloated belly, and buttocks. He's got a bit of a loss of buttocks, probably from some weight loss, right? So what we recommend is, if you get diagnosed, we recommend that all first degree relatives, that is siblings, children, and parents, they should get a blood test for celiac disease. Some people will recommend second degree relatives, so grandparents, uncles, and aunts. But some people say maybe it's not cost effective. But what I usually recommend is go and ask your family members. And if any one of them has any symptoms, they should get a blood check, be screened for celiac disease. And I can tell you in my own practice, quite commonly I find once a child is diagnosed and we screen the mother and father or a sibling, next time when we meet in a few months, the mother said, oh, I got diagnosed, or dad said, I got diagnosed. Right? So celiac disease presents in three broad patterns, what we call clinical patterns. One is called symptomatic celiac disease, and we've talked about that already. This could be classical or typical or non-classical or atypical. So classical would be with diarrhea and malabsorption, belly pain, diarrhea, weight loss. And non-classical would be the things I mentioned, right? Mouth sores, headaches, infertility, liver problems, anemia. Those are called non-classical presentation. So here your blood test is positive and the biopsy is positive, and you treat these people with a gluten-free diet. Second way they present is called, in the past we used to call it asymptomatic or subclinical. Here your blood test is positive, your biopsy is positive, and you got screened because you were in a high risk group, like a family member, and you treat them with a gluten-free diet. And third is called potential celiac disease. So you got screened for some reason, your blood test was positive, but your biopsy is normal, negative. So these people need to be followed up closely. They don't need a diet at this time because the bowel is normal, but they will develop celiac disease in the future, so they need to be followed closely. So this is the celiac iceberg, right? You can't go to a celiac talk and not talk about celiac iceberg. What does it mean? That the tip of the iceberg is your symptomatic disease, and the vast majority of people are under the water. So they have subclinical or asymptomatic or potential celiac disease. Now the Canadian Celiac Association did a couple of very good surveys. One was done almost 17, 18 years ago. And one of the questions that was asked in that survey was, how long did you have symptoms before you got diagnosed with celiac disease? And the average duration of symptoms before a person got diagnosed, these were adults by the way, was almost 11.7 years, almost 12 years. So this is, they had symptoms for 12 years before they got diagnosed. Somebody thought of celiac disease. And then there was another big survey looking at coping with the gluten-free diet, and we thought we should ask the same question from participants. This was almost 6-7 years later, and we asked the same thing, and you can see that it is still 12 years. So what it means is that over time, we still have a lot of problem with awareness, and delays in diagnosis are very, very common. And why is that? One of the reasons is that when we teach our doctors about celiac disease, this is what the images we are showing them in our textbooks, right? This is a textbook of pediatrics, and here you see a child with celiac disease. So you don't need to be a rocket scientist to actually make a diagnosis. This child is miserable, he's got a big belly, he's got, wasted, and he looks very unwell. Same is with adults. If you look at a textbook in medicine for adults, these are the kind of pictures they are putting in textbooks. But the reality is that we're not seeing this now. So this is a child with celiac disease that we just saw recently. He looks very well nourished. All he had was constipation and a slight bloated belly, what we call a pot belly, which is not uncommon in sort of toddlers. So this is the celiac disease of today. This is the celiac disease of the past. But we are looking for this and we're not finding celiac. So I took this quotation from Dr. Peter Green's book. Dr. Green is a big celiac specialist in New York, and he compiled some stories from his patients. And one of the patients said, I know of someone who just got diagnosed because a doctor retired, right? So especially the old time doctors, they're used to seeing those images of thin and wasted patients. I think a newer breed of doctors perhaps is a little bit more up to speed with awareness. So this is why we called celiac disease a clinical chameleon. So chameleon is this little lizard that adapts its skin according to the environment. I don't know if people can see this. So you have to look very carefully to actually see the chameleon, here the chameleon, right? So this is very true for celiac disease because it can present with any symptom in your body. Brain, skin, liver, blood. So you have to get very close to actually make a diagnosis of celiac disease. So I think this is a very good analogy of that of a clinical chameleon. And we know that if we start to look for celiac disease, we will find it. This is a very interesting study. It was about almost 10 years ago across North America. And what they did was they took patients who were coming to see their family doctors with a variety of symptoms. So this is a list of symptoms. And they said, if you have any of these symptoms, we will do a celiac check on you. So when they did that, they found that there was a 42-fold increase. It's not 42%, 42-fold or 42 times increase in the diagnosis of celiac disease. So if family doctors look for celiac disease, they will find it with any of these kind of symptoms. So how do we make a diagnosis? So we do blood test, what we call serology. This is the greatest advancement in the diagnosis of celiac disease over the last 20 years, is availability of blood test. And then we do a biopsy to confirm the diagnosis. And there's a long list of blood tests that have been available over the last 30 years. And you don't need to worry about this. You need to worry about this one in red. It's called TTG, or tissue transglutaminase antibody. And this is the blood test that we refer to when we say, did you get a blood test for celiac? Around the world, this is the recommended blood test for a start, is to do the TTG blood test. And here is a very simple scheme of things you can follow. So you have symptoms. These could be bowel symptoms, outside the bowel. You see your doctor does a good history, does a physical exam, and checks your TTG blood test, TTG antibody. If the TTG antibody is abnormal, then you go to have a scope test and a biopsy to confirm the diagnosis. If your celiac blood test is normal, celiac disease is very unlikely. It is very important to remember that you have to be on a regular diet, gluten-containing diet, for your blood test to be positive. If you remove gluten, your blood test will become negative pretty quickly, within a few weeks or months, and then your test will be false negative. So we really, really encourage people not to go on a diet before you get a blood test to make sure that you don't miss celiac disease. So you do a biopsy. If the biopsy is typical for celiac disease, you go on a diet. If the biopsy is doubtful, then there are other ways we can try to confirm the diagnosis. In children, there is a non-biopsy approach that is also used, and your doctor will be able to discuss that. But it's not applied to adults, it's only for children. So you need a scope test, right? This is a scope endoscope. People are put to sleep shortly for 5-7 minutes or given sedation. So it's not an operation, there's no cuts or nothing, it's all done through the mouth. We put a little tube down with a little light and camera, go inside the bowel, and we take small pinches from the lining of the bowel called biopsies. And then we look under the microscope, like the images I showed you, and we confirm the diagnosis. So endoscopy is the best test to confirm celiac disease. So this is one of my take-home messages for people who are listening, that celiac is a lifelong disorder. It has serious implications of going on a gluten-free diet for life. There is risk of getting other autoimmune diseases. One needs to have regular follow-up. So the diagnosis should not be taken lightly. So gluten-free diet should not be started without confirming the diagnosis of celiac disease with a small intestinal biopsy or small bowel biopsy. Because it is bad to miss the diagnosis of celiac disease, but in my view, it is even worse to diagnose it in somebody who does not have it, because you get branded for life. So this is really, really important to keep in mind. So the last part we'll come to is treatment and management. Well, the management of celiac disease is relatively straightforward, and that is a strict gluten-free diet for life. So there are two things to focus on. The diet has to be strict. So to get the best benefit of the diet, you got to remove gluten completely. I sometimes see adolescents and ask them, are you gluten-free? And they say, I'm 90% gluten-free. Well, 90% is not good enough. You got to be 100% gluten-free. Because even if you take small amounts of gluten, it will cause all sorts of problems and injury to the bowel. So it has to be strict, and it has to be for life. Unfortunately, this is a genetic problem. People do not outgrow celiac disease. Once a person has celiac, it's going to be a long-term problem. So no food or drinks with these three grains: wheat, barley, and rye. And these are sort of the principles of management. It is absolutely critical that you see a dietitian, a skilled dietitian with expertise in gluten-free diet, to get all the information. There are a lot of good web resources, including our own Canadian Celiac Association, but you got to meet with a dietitian, because this diet is not easy when you get started. You need to educate yourself about celiac disease. It has to be lifelong adherence. Any nutritional deficiencies like anemia, low vitamin D, iron needs to be corrected, and you need to take supplements. Access to an advocacy group. There is good evidence from around the world that people who join a support group, they tend to do better. And we have an excellent organization. We are very fortunate. There is a single organization in Canada, which is CCA. So I really encourage everybody to become, we don't have that membership model, but join the group and contribute to the activities. And then continuous long-term follow-up by a multidisciplinary team. So that's your doctor, your dietitian, your social worker, your psychologist as needed. So the CCA has some excellent resources. There are two very good documents that you can access, open access, that you can actually keep for yourself and take it to your family doctor as well, about management and diagnosis. So these are some of the challenges, because this diet is complex. Availability is still a challenge, right? In smaller centers, smaller communities, you can't get gluten-free foods. It is still expensive compared to a normal diet. It is complicated because of risk of contamination. Nutritionally, one can have problems because sometimes the gluten-free flours are not fortified with iron or folic acid and other vitamins. And as we all know, people who are on a gluten-free diet, it can be socially restrictive. So birthday parties and sleepovers and camping and traveling, it is a little bit more challenging. And above all, if it is lifelong. So these are all good reasons for not just experimenting with a gluten-free diet, but to make sure that one doesn't have celiac disease or a gluten-related disorder. So just to summarize, because we're just finishing up. So I like to, these are like sort of the take-home messages. The celiac disease is a very common disorder, very, very common problem, affecting about 1% of the population, both in children and adults. Number two, celiac disease can present in a variety of ways, both bowel and outside the bowel, typical and atypical symptoms. Number three, if celiac disease is suspected, one should start with the serological test, which is the TTG blood test, and that should be done before attempting a gluten-free diet. Now, this TTG test, other than Ontario, it is on the public checklist for all provinces, meaning any family doctor can order that. Unfortunately, in Ontario, there is still some issues with that. So patients may have to pay for that. And the CCA has been doing a lot of advocacy to get that changed, but the test is easily available. And finally, improving awareness of celiac disease is key if we want to make life better for patients. So both at medical, professional, healthcare level and at a societal level, We have to spread this word that celiac is not written on the face of the patient. People, in New York, for example, a good majority of a good number of people with celiac disease are actually obese at diagnosis. Now, you've never thought a celiac patient would be obese, overweight, but that's happening. So celiac, you can't tell whether the patient is obese or not and may or may not have celiac disease. So one should be really have a very high index of suspicion. And I tell my own patients and families, talk to your family doctor and say, can I get screened? Can I get a blood test for celiac disease? And you'll be surprised. So lastly, I again encourage everybody, thanks for joining in, and I would encourage people to become part of the celiac group. As I mentioned, we have a great organization. They're doing a lot of advocacy. You don't realize how much work goes behind the scenes with Melissa and our dietitian and everybody else. They're all volunteers. Our professional advisory council, this whole issue of gluten-free oats and certification program, it is only possible with your support, especially with your financial help. And I'm going to stop here, and I'll be very happy to take any questions. And we would also like to get your feedback. It was basically a Celiac 101. I just wanted to point out some important aspects of celiac disease, and hopefully this was useful, but we would like to get some feedback from you. Thank you.
Thank you very much, Dr. Rashid. It was an amazing, comprehensive overview, and I'm sure it's going to be very helpful to a lot of people to assist them going forward. Just before we move into questions, I would like to point out our website, when we are sharing some more videos from Dr. Rashid, along with handouts that you can share with your doctors to start a conversation on the diagnosis for celiac disease. If you're already diagnosed, please make sure to join our CCA moderated Facebook group, sign up for our newsletters, and check out our YouTube channel for past education sessions. We have amazing uploaded videos there. And if you've enjoyed today's presentation, please consider making a donation to help us to continue delivering programs and services. We are midst of our spring campaign. Please visit www.celiac.ca and click the donate button. At the end, we will also have our Executive Director, Melissa, announce the winners for the 3 prizes for today. You will also receive a link for the evaluation. Do let us know how we did tonight. We hope you complete it so that it can help us improve and also offer suggestions of topics you would like to hear more about. Now going on to questions, I have quite a few of them. And the first question is, can you get Dermatitis Herpetiformis just on your hands?
What was the first part, sorry?
Can you get DH on just your hands?
Yes, absolutely. You can get it. It's said that it's usually symmetrical, but it doesn't have to be, because diseases don't follow a textbook pattern. So you can get it on your hands. Keep in mind that people with celiac, they are more prone to getting other skin problems. For example, eczema and psoriasis especially. Psoriasis is more common. But you can get DH on the hands, you can get them on the feet, you can get them on the elbows and knees. Absolutely, you can, yes.
Okay. Second question is, one of the participants had asked regarding her daughter that she's been gluten-free for quite some time now, and they do have an aunt in the family who has celiac disease. So what should she do now to get properly tested?
So I'm presuming that the diagnosis was not made in the child, and she got put on a gluten-free diet. So so there are a couple of options now. One option is that stay the course. If she's doing well, she can carry on with the gluten-free diet. But I think at some stage you would want to know for sure, especially when she gets older, right? She would want to know for sure. So then our option is to do what we call an oral gluten challenge. So this will have to be discussed with your family doctor and the gastroenterologist. So I don't know the age of the child. We don't like to challenge young kids, say under 6-7 years of age, because it can affect their permanent teeth that are in development. So after 6-7 years of age, so what that involves is setting up a meeting with the gastroenterologist, setting up a biopsy time, and then sort of 6 to 8 weeks prior to the biopsy time, the child starts on gluten-containing diet, or at least some gluten. And the recommendation is sort of 1 to 2 slices of bread equivalent every day of gluten. Or it could be pizza or muffin or something that has gluten. And we continue with that, and then he or she gets a biopsy. Now that depends. In adults, it's a little bit quicker. In kids, it is usually anywhere between 6 to 8 weeks or sometimes 12 weeks. And we do their celiac blood test as well, right? And that would help make a diagnosis. Another approach would be to do a celiac genetic test, right? As I mentioned, you need to have one of those two genes to get celiac. So if your daughter's blood test comes back negative, not the celiac blood test, we're not talking of TTG, because that would be negative because she's on a gluten-free diet. But the genetic test is done first. If she is negative for the genetic test, then there is no need to pursue this matter any further. There's no need to go on a challenge or stay on a gluten-free diet because she doesn't have celiac disease, right? If
So,
she,
doctor, the genetic test you'd have to pay for, correct?
yes, absolutely, yeah. No, it depends actually. It depends on your physician and the availability. If it's done through a hospital lab, it will be covered. It's also available as point of care testing. There are a couple of manufacturers in Canada that will offer that you can get it done. So it all depends how this is approached. Like in our province, for example, I need to make a case. It's an expensive test, so we need to make a case. So if we can make a case that we can avoid a biopsy, maybe she doesn't need a biopsy. So in that cases, it might be covered. But this all has to be planned. So don't just start her on gluten. Talk to your family doctor, get a referral to the gastroenterologist first, have a meeting, and then make out a plan. So those are a couple of approaches that you can use for your daughter. If she has a family member with celiac, I guess that does put her at a higher risk, but by no means it is definite that she has it.
We do have a gluten challenge document on our website. So if it comes time, if that's the direction, we do have some advice from our professional advisory council that you can download and actually take to your doctor.
Yeah, and there is some variability as to how much gluten and how long. So what I gave you was a broad, just a guideline. It varies, and the problem that happens with gluten challenge is that if you really have celiac, you can get pretty sick, right? Because if you get sick with contamination and you now start taking gluten in larger quantities, so you're going to get sick. So this is why it's important to have it planned out, because your biopsy may be done more quickly if the child becomes more symptomatic. You don't have to wait for 8 or 12 weeks to get a biopsy, but it has to be planned out.
Okay. So next question is that if I have celiac disease, do my parents and sister need to get a biopsy?
So they need to get screened with a blood test first, right? That's a screening test. And that's the beauty of the blood test, is because you don't need a biopsy if your blood test is negative. It's about I would say 90% accurate blood test, as long as you're not on a gluten-free diet. So what I would recommend is they get a blood test. If the blood test is normal, then they don't have celiac disease with 90% surety. If the blood test is positive, they have about a 90% chance of having celiac disease, and then they should get a biopsy for confirmation. Again, this is a broad guideline. There are always exceptions, right? There will be people whose blood test may never be positive and they have celiac disease, but that's an exception. And similarly, you can get a false positive blood test, especially if it is not very strong positive, it is just mild positive or borderline, that we can see in even non-celiac people. So I would suggest that they don't need a biopsy as the first thing. They need a blood test, that TTG blood test first.
One of the participants is asking, there is so much of material on the web about research for celiac disease and potential cures. There are different types of cures, either to break down the gluten before it gets absorbed, or other cures around teaching the body how to accept gluten. What are your thoughts on this? Is there a hope something will be discovered in near future?
Yes, so I mean that could be a whole talk in itself, right? So obviously the celiac community, they want a cure, they want a fix because of the challenges. Many people, despite claiming to be strictly gluten-free, they still have problems, they still have symptoms. So I think we are living in very exciting times, because only in the last sort of 5 to 10 years that people have started to look for a cure, for a more permanent cure beyond the gluten-free diet for celiac disease. So I think there is some hope on the horizon. The therapies that are being tried and that are in clinical trials now, keep in mind that they will not offer a cure in the sense that you can eat a normal diet. I mean, you have to be realistic and not have the hopes so high. So the medication that will be coming out first would be that you can take some gluten in certain exceptional situations, or you can take those medicines, and if your diet is contaminated, you won't have the damage to your intestine. So you never know, right? Big discoveries are happening in medicine all the time. So I think we need to be hopeful. We need to fund these kind of research. We need to be part of these surveys and research studies. That's the only way we will ever find a cure. And I'm quite hopeful that this will be coming. I can't give you a time frame because we don't have that kind of information.
We've got a great actually webinar on our YouTube channel on upcoming clinical research. So I do encourage that individual to check that out.
Yeah, and we have one of our participants asking us, due to the COVID, the endoscopy was delayed, and he has gone gluten-free just to feel better. Eventually, he will be called for the endoscopy, but at this point, how long should he eat gluten to get an accurate endoscopy?
Yeah, so that's what it means is that endoscopy now would not be very helpful, because depending on how long the person has been on a gluten-free diet, if it's been sort of few weeks or few months, then biopsy will not be very helpful. So make sure that you talk to your gastroenterologist to cancel the biopsy, because you don't want to go to a biopsy on a gluten-free diet, right? That's not going to be helpful. So in that situation, what you will need to do is to go on a gluten challenge again. So again, it depends in adults is usually a little bit shorter, perhaps 4 weeks. In children, we challenge them a little bit longer, anywhere from 6 to 8 weeks, even 12 weeks. So that's something you'll need to discuss with your gastroenterologist.
Okay. So one of our participants says, excellent presentation as always, Dr. Rashid. My question is, if you have already been diagnosed for over 40 years and are following a strict gluten-free diet, what is the probability of being diagnosed with neurological issues at this time?
Right. So this is very interesting, because there are some symptoms that occur because of gluten, right? So those symptoms will go away. So I tell people, patients, that anything to do with celiac disease will get better and will resolve eventually, as long as your diet is strict. But you could have a second autoimmune disease running parallel to celiac disease, which may not improve because it's not from gluten. It's just because you have a second disease. So for example, let's take up type 1 diabetes, right? So going on a gluten-free diet will not fix type 1 diabetes or the thyroid problem. There is some evidence that if you are on a strict gluten-free diet long term, your risk of getting a second autoimmune disease may go down, but it doesn't go to zero. You still are at risk. So in cases of a neurological problem, that could be a second independent autoimmune disease. For example, neuropathy, I mentioned, those pins and needles, the inflammation of the nerves. Sometimes it's nutritional. You have low vitamin A or folic acid or B12, and once you get fixed, your bowel is healed, you absorb those nutrients, that neuropathy will go away. But that neuropathy could also be an autoimmune neuropathy, which will not get better with the gluten-free diet. So it all depends what neurological disease the person has.
Okay, so we have another question along the same lines. If you have gone gluten-free, how long and how much of gluten should you eat before going for a blood test?
Yeah, so that would be same as going for a biopsy, like what we call a gluten challenge. So the general recommendation is like 2 slices of bread for an adult, equivalent of gluten every day. And perhaps I would say 4 to 6 weeks, unless you get very sick quickly. I would say at least 4 to 6 weeks, and then you can get a blood check done. Keep in mind, again, these are broad guidelines. There's a lot of individual variation, and there's a lot of individual sensitivity to gluten. Because when you talk to people with celiac, some of them will tell you, I take little bit on my tongue and I get symptoms. a little bit goes in my body. Whereas other people said, listen, I can take some gluten, I don't get a lot of symptoms. So there's a lot of individual variation between people. So similarly, some people will get challenged and their blood test will turn positive very quickly. Some may take a much longer time. But that's what you need to do, is to go on a regular gluten containing diet at least for 4 to 6 weeks.
So one of our participants is asking, in terms of the COVID pushing the elective procedures back, why should you wait for a biopsy to confirm celiac disease? Is it just because it is a lifelong commitment to gluten-free diet? And this can be seen as pretty unpleasant.
Right. So I'm going to take the issue with the adult first. Because in pediatrics, if the child has a very strong positive celiac test, what we call over 10 times normal, then we have another approach that we do a second type of celiac test, and then we do the genetic test. And if they're all positive, then the person has celiac and they don't need a biopsy. But this is not applied for adults yet. Now, the problem is that you can get a false positive test with celiac, and you may not have celiac disease. This happens, and I've seen it in my own career many times. And it can be quite positive, especially when you have like a stomach flu and somebody did a blood test and it became positive, and after a few weeks or months it becomes negative. So I think celiac disease, as I mentioned in a couple of slides, it's a very significant, serious, long-term disorder. We have an excellent treatment, no doubt about that, but it has some dietary limitations, some lifestyle issues, some social restrictions long-term, and then the risk of your children having celiac disease and getting another autoimmune disease in your lifetime. So I think for all those reasons, you will need a follow-up. You need annual blood tests to make sure things are fine. So for that reason, we should take the diagnosis very seriously. And this is the message that I give to my own families and patients who just want to try. I said, at least get a blood test. That's your starting point. Now, in the COVID situation, and we've suffered this as well in children, and so we can't biopsy them. So we tell them, okay, your other option is, if you're having a lot of symptoms, you go on a gluten-free diet, and we'll deal with this afterwards with a challenge. If your symptoms are not bad, they're mild, just hang in. Just hang in there for a few more months till you get your scope and a final diagnosis.
Okay. So a question is, just to clarify, do you need both genetic markers or one of the two?
You just need one of those two. The DQ2 is more common, about, I would say, 95%. DQ8, about another 5%. You may have both, and that increases your risk a little bit more, but you need either one of them.
So one of our attendees is asking, should I see a registered dietitian if I have celiac?
That would be my recommendation. A registered dietitian with experience in gluten-free diet, because keep in mind, just like there are specialists amongst doctors, there are specialists among dietitians as well, and some dietitians may not have a lot of expertise. So I would seek out one, certainly registered dietitian, and find out that they have experience with gluten-free diet. I think at least one initial meeting would be very helpful, and after that you can meet with a dietitian as needed. There's a lot of stuff on the internet, on our CCA website, but there's no face-to-face meeting at least once is very, very helpful actually.
Is there an advantage of getting tested for celiac if you have been gluten-free and the diet has been helping you? Will this knowledge help us towards other illnesses? There are multiple questions, so maybe we can take one at a time. Is there an advantage of getting tested for celiac disease if you have been gluten-free and the diet is helping?
Yeah, right. So you, as I mentioned, if you go on a gluten-free diet, let's say, without any investigation or anything, no blood test, nothing, right? You go on a gluten-free diet and you feel better. There is no guarantee that this is celiac disease. For example, you could be feeling better because you may have a wheat allergy, which is not autoimmune, which will not damage your bowel, which will not put you at risk of getting other autoimmune diseases. Number one. Number two, wheat has other things in it that a person may be intolerant to. And I didn't go into detail into that area. And one of them is a group of carbohydrates or starches or sugars called FODMAP. And the FODMAP are present in all foods. Wheat is a high FODMAP item. And some people have intolerance to FODMAP. They just don't sit well with the bowel, and you can get gas, bloating, diarrhea, cramps, and all kinds of symptoms because of FODMAP. So when you cut out wheat, you're actually cutting out high FODMAP food. So you feel better after that. So getting better on a gluten-free diet, keep in mind, is no guarantee that it is celiac. It could be celiac, but it doesn't confirm that. That's why you need a blood test or a biopsy for confirmation. So one of the things we did, a 5-minute piece, this on on our website, is what if you have gone gluten-free based on a diet, and what's your next step actually. So I think it'll be worth listening that as well.
Yeah. The next question is, will the knowledge of knowing you have the celiac disease help us towards other illnesses?
Yes, of course, right? If you have celiac disease, then you are a little bit more cautious about getting other problems, other autoimmune diseases, for example. So that certainly having that knowledge of your own health, then you need. I mean, you plan out things differently. You plan out your travel, all kinds of things. So I think knowing that you have celiac disease, which is a very specific disorder, autoimmune disorder, I think it would be personally, if I would want to know if I have it or not, so that I can modify my life according to that reality.
Okay. So one of our attendees says, thank you. And we have one of the attendees asking, the family doctor for a particular client thinks she may have PCOS.
That the person has PCOS.
Yes, the family doctor thinks so.
Okay, so I believe PCOS stands for polycystic ovarian disease or syndrome.
Yes.
Yeah, so that I don't think it is directly related to celiac disease. Now it can cause some symptoms, for example, menstrual problems, weight gain, those kind of things. But it's not a symptom that necessarily would qualify to be screened. For example, there are some problems that we recommend screening for celiac. For example, irritable bowel syndrome. If your family doctor says, you've got IBS, I would say, listen, I want a blood test for celiac disease, because I know a lot of gastroenterologists, they don't see referrals on people with a diagnosis of IBS from their family docs until they have had a TTG blood test done. It's certainly the case here in Halifax. So that's a very specific type of a problem. Or somebody has a lot of fatigue, tiredness. So rather than blaming it on chronic fatigue syndrome, I say, okay, let's check you out for celiac disease. But polycystic ovarian syndrome, I don't think necessarily qualifies for screening. And I don't think there's a direct link with celiac disease either. I don't know if that answers the question.
We have one question.
We'll do one last question. How's that
yes,
sound?
one last question, please. Would celiac disease possibly be a factor in recurring mono?
Recurring mono.
Mono infection, mononucleosis, which is a viral infection. I don't think so. Although we call celiac disease an autoimmune disease, the person is not immunocompromised, or they're not immune suppressed per se, unless you have another autoimmune disease, right? Like if you have diabetes and other things. So celiac disease itself, once you get properly treated, your immune system is good enough to fight off infections, right? So you should not get recurrent mono just because you have celiac. Now, if you are not following gluten-free diet, then that can set you up a little bit more about other infections and those things. And a lot of that is nutritional, right? So you may be low in zinc and other nutrients which are important for our immune system, vitamin C and vitamin E. So in that case, the person may be at risk of getting other infections, but not celiac, well-controlled celiac per se should not put you at risk of recurrent mono.
Okay. So to our attendee participants, if you have any more questions, please email them to info@celiac.ca and we will try and get back to you on them. I would now like to pass on the stage to Melissa, our executive director. She would like to announce the winners for today evening.
Thanks, Gauri, and thank you, Dr. Rashid, for a really informative session. I've always learned something from you, so thank you very much. I hope everyone enjoyed it. So we have 3 winners who are going to win a $10 Promise gluten-free coupon, and hopefully when we do announce the winners that you are Canadian and that you're 19 and over, we'll confirm the details in your registration. But I wanted to congratulate Amy Campbell, John Ruby and Sherry Deeks for participating tonight, and congratulations on winning the coupons.
Congratulations. Okay, so now I would like to thank all our participants, our presenter, Dr. Rashid, for taking time out from his busy schedule and helping us learning more about this, and our sponsors for tonight, Promise Gluten-free, and Melissa, our executive director, who is here with us today. If you have any more information you'd like to receive, email us. We will try and get to you. Meanwhile, we wish everyone health and happiness. Thank you very much for being here with us today.
Good night, everybody.
Thank you.
Bye-bye.
Bye-bye.